We would now like to welcome our esteemed panel of guests who have a wide range of expertise across the health industry and cancer sectors. We look forward to hearing their thoughts on the work and perspectives we've just heard about. I would like to introduce Neil MacGregor, Managing Director for BMS in Australia and New Zealand. Neil is an experienced pharmaceutical leader with an extensive career that spans 5 continents. He's also a member of the Board of Directors of Medicines Australia. Holly Masters, Chief Executive Officer of the McGrath Foundation. Holly is responsible for leading the organisation to deliver on its mission of ensuring every person experiencing breast cancer has access to the free support of a McGrath breast cancer nurse wherever they live in Australia. And Delaney, patient advocate. With more than 20 years' experience in healthcare, mainly as an IVF scientist, Caitlin has a broad knowledge of the healthcare industry. Enhancing the patient experience has been her passion, and this was placed in the spotlight when she was diagnosed with stage 4 ovarian cancer and faced being the patient herself. And she's the founder of Carefully, an organisation with the vision to make compassionate care a core competency for healthcare industry in Australia. Professor John Zalcberg, Head of the Cancer Research Program in the School of Public Health and Preventative Medicine at Monash University. His clinical research interests include GI cancer and the quality of care, and he's published more than 300 articles in peer-reviewed journals. He continues to be actively involved in trials in GI cancers and is an active clinical practice in that area too. We'd also like to welcome back Jane Tiller to the stage as a panel guest. The panel discussion will be facilitated by Christine Cockburn. She's the Head of Patient Support and Operations at Rare Cancers Australia. Christine is passionate about understanding the patient experience. She's a health sociologist and is currently undertaking a Masters of Public Health at Monash University. Please welcome the panel.
Thanks, Sophie. Thanks so much. Thanks all for joining us for this very exciting conversation. We've been set up beautifully, I think, this morning. Caitlin, can I go to you first? Everything that we're talking about today and all of the work that has led to where we are today is to improve the reality that you're actually living right now. Can you talk to us about opportunities from your perspective and your experience that have been made or that perhaps we're not leveraging?
Yeah, so firstly, I'd like to say thank you so much for having me here, Christine, and Rare Cancers Australia. Including that patient voice is critical, and I'm really pleased to be here today. I wish it was under different circumstances though. I unfortunately do have stage 4 ovarian cancer, and I was diagnosed in 2017, and I should not be here today. If I had not advocated for my own health and thought outside the bubble, challenged people's perceptions, I wouldn't be on the treatment I'm now. And I've just found out 2 days ago that all the cancer that was in my liver and my lymph nodes, they couldn't see it on the PET scan. Yay! So I'm happy to say that I've got good news today, but I had to work really hard to get that treatment. As soon as I was diagnosed, it's like a triple diagnosis. You get a cancer diagnosis, then it's advanced. It's spread all throughout my body, up into my diaphragm, all over my spleen, my liver, it's everywhere. And then I've got a rare cancer. So not only do I have ovarian cancer, I have a rare type of ovarian cancer. I can't get into clinical trials. I can't get PBS listed drugs. Avastin kept me cancer free for 2 years. I had to self-fund it for the 2nd year, and as soon as I stopped it, my cancer came back. But at the time, everyone said there's no evidence. Now they know, oh yeah, we should have kept you on Avastin. I can't wait for that evidence. I need to be ahead of that data, and I am the data. So I am my own clinical trial, and the drugs I'm on now have kept my disease stable since July last year. I recurred in January last year, and it's not spread anywhere else, and now it's gone.
Congratulations on the wonderful result this week. I think we'd all like to applaud just a little bit. Very happy for you. It's really great to have you here today. John, Caitlin touched a little bit on clinical trials and how it becomes part of the everyday reality for people living with advanced and rare cancers. Clinical trials are, by definition, designed to create robust data and to get drugs to market. They are also the best and sometimes last chance for patients to access new medicines. Can the two things coexist? Can they be everything to everybody?
Yeah, thank you, Christine, and also echo Caitlin's gratitude for being invited here today. So Look, I think clinical trials, the way I think about clinical trials broadly is that it's essentially a way of saying, how do we do healthcare better? So it forces us as a community to think about the way we do things now and whether we can improve on that. And it forces us they force us as a tool, they force us to think about ways that we can improve. So they're a really important part of the health system and the ecosystem we live in. Having said that, though, they're challenging, and they do have challenges. And I think we're getting a sense of that. Are we talking about the patient of today or the patient of tomorrow? So the patient of tomorrow walks into my office as a clinician, and he's a gentleman with advanced colorectal cancer, say, or advanced pancreas cancer, or advanced esophageal cancer, and says, thank you for that. We've had a conversation. The treatment you've recommended sounds promising. Do you think it's going to help me? And I can say, we just saw a report, a publication of a clinical trial that tested that treatment, and it very substantially improves survival. So this is we think this is a good treatment, and I think this would be a treatment that would help you. And there's a much more complex discussion, an involved discussion, but that's for the patient who walks in today.
Yes.
And the reason I can say that is because a trial was done.
Right.
And the trial allowed, in the past, and it allowed us to turn up today and say, I think this is the right treatment for you because we have evidence to support that. Now the patient of today, though, says, well, I've got advanced colon cancer. What treatment should I have? And I say, I've got a clinical trial for you. And the two, this is a comparison of two treatments. Now, there isn't in this example, it's, well, which is the better treatment for me? And I say, well, we don't know. If we knew what the right treatment was, we would give you that treatment.
Right.
But we don't know what the best treatment is. So we're doing a clinical trial comparing A and B. And that's the tension, right? So on the one hand, the patient of tomorrow who's in my office now says, I'd like to know what evidence there is to support the treatment you're recommending. But the patient of today is saying, well, we don't know how the best way to treat you is. We have promising treatment, but not all promising treatments work. And on average, about 50% of at least pharmaceutical company trials are positive and the others are not.
Yeah.
So they're negative. So that's the tension, I think, that we have with clinical trials. And where it gets particularly challenging is where we start to think about placebo-controlled trials.
Yes.
But perhaps I'll stop and see if there's
Thanks, John. That's a really good thing to keep in mind, is that patient of today and the patient of tomorrow. Kind of got a foot in each camp there, haven't you, Caitlin? Jane, can we just touch a little bit in the context of treatment and what you spoke about earlier with the social contract? Why is that important to this conversation?
Yeah, the social contract is important because it's not something that we're striving for. It represents, it's a demonstration of what is required for things to work in society. And we all have this idea of when things don't go right. People aren't getting funding, the government's not spending money well, or we look at things like the insurance industry. We see the Royal Commission, we see that industry isn't complying with what we all see as fair with the social contract of how things should work. And so it's not so much that we need to aspire to this, demonstrating a social contract. We just need to understand what is necessary and make sure that all parties are kept accountable and are really looking at that in the right way and making sure that each party's fulfilling its role so that those things do work and our society works well.
That's really interesting. So Neil, from an industry perspective, if we're talking about that social contract, you're part of a global network. Australia doesn't operate in isolation, particularly when it comes to medicines and pharmaceutical access. We actually hear, this won't be the first time you've heard it, but Australia's falling behind. Yep. We're not at the cutting edge. Is it true?
I think the answer is yes and no. I think, back to Jane's stellar presentation this morning, there are many elements of the Australian healthcare system that are fantastic, access to medicines for patients. However, if you're a patient where there's not a treatment or the treatment is going through our regulatory reimbursement processes, time really matters. And I think right now what we're seeing an era of patient centricity, as we talked about today, and we're seeing global movement. So globally within Bristol-Myers Squibb, now for all of our pivotal trials, we must have patient advocacy involved at the design stage, looking at the outcomes for patients, the lived experiences, which is something that we're really proud of, and I think many pharmaceutical companies are doing that. And we're even more proud that in 2022, this has been a US-centric process, but actually Australia is going to take part as one of the first international countries starting in 2022. But you also see movement here in Australia where we have had some focus and some energy. We've had a report for a number of years called Broadening the Evidence, where we've talked about what really matters. And we did a gap analysis versus other international countries and saw 10 real focus areas. The first of them was trying about how can you take the patient and actually make sure that their needs are included in the HTA processes. Working with the Patient Voice Initiative and HTA International, we actually simplified that, and really proud to say earlier this year, we actually saw a pharmaceutical approved in Australia and reimbursed inside 12 months from the data drop globally. That is unheard of. And for me, that sets the new benchmark. Now, where do we go with that? The reality is a lot of it's stuff that's included in the House of Representatives piece we'll talk about later on today. But most importantly, it's about, as a community, working together. I see that the horizon scanning piece and understanding not just the pharmaceutical perspectives, the patient side, the government perspective, that community and the social contract needs to work together, because we need to do much more in terms of that fulsome view of patient care here, which includes nurse navigators, includes the physician, includes the patient themselves, and taking control of their treatment and being informed. So I think the short answer to your question is we are being left behind if you look at specific metrics as we're looking at access to patients, and we've got to do much better there. But there are some elements where when we work together, we can improve that.
Yeah. That's really promising, Neil, to hear that you've got such progressive patient involvement in medicine development. Holly, Neil just touched briefly, and our report touches also on, we have questions from the audience, all about navigation.
Hot topic.
And we've got the lady here to talk about it. The McGrath model is broadly accepted as being the gold standard of what I'd like to call a guardian angel, I suppose. Having experienced the service myself and now supporting rare cancer patients, I can vouch for the difference in the experience. Is there some hope for other cancer patients in Australia to have dedicated navigators in a similar way to what the breast cancer patients of Australia have had for all these years?
We really hope so, because we know what a difference it makes. I can put a dollar figure on it in terms of the release capacity in the system, but also the improved healthcare outcomes for the patients and the loved ones. So we shouldn't forget that it's not just the person-centred aspect, it's about their structure around them as well. So those that love them and care for them. And over the last 15 years, we've been able to build this kind of model, which absolutely, as you say, is gold standard of supportive care nursing, that is not just gold standard here, it's gold standard internationally. And one of the reasons it works so well is because the nurse has a continuity of care with that patient, and they are experts in their local area. And one of the challenges across Australia is there are amazing services and provisions. There are also many gaps. Is also dictated by where you live and what it looks like locally. Every patient is different, every cancer is different. And the nurse is able to connect the patient and their loved ones to all of the services locally and nationally that will work best for them in terms of what is important to them. So they will use screening tools in order to make sure that they really hear from the patient, and that their voice is represented, whether or not the patient is part of, for example, a multidisciplinary team meeting. The nurse is the respected voice of the patient in that. We've been able to codify this now as the McGrath model of care, and the one thing we believe passionately in is that it has to be relevant more broadly. And so we have been working with a group of leaders across the sector. We've just submitted a scoping study of what this could look like. We've drafted a new kind of form of this model of care, and we believe it's perfectly possible, because actually a lot of what people need is out there. They just don't know they don't know it's there. And they also, the conversation earlier about information and being able to distill that information to make the right decision in a quick way is what helps that to sort of facilitate that process. So I genuinely hope, we believe that no one should go through cancer without care. You know, it's something that we're absolutely passionate about, and I think collectively, through a collaborative approach, that's what allows us to have a unified voice, and I believe that's the way we're going to have the greatest impact.
That's really encouraging. I talk to patients all day long that are really self-navigating, and it's such a hot topic, and quite rightly. It makes a big difference once they have an anchor and a guardian angel. Caitlin, I wonder, please, I'm going to come to you because I know you're passionate about this piece as well. Caitlin, would a navigator have made a difference for you?
Oh, yes. Just hearing you speak about that. When you're diagnosed, you're just lost. You're in this wilderness, and I'm health literate. I've got a health background. But you feel like you just feel rejected, you know? You feel like you haven't got the popular cool cancer. And I know that sounds terrible, but you do feel like that. And you're sitting in the chemo ward and there's someone with a different cancer next to you who's got their own dedicated nurse, and you can't even get a drug for nausea on the PBS that they're getting for free. It's that inequality.
It's heartbreaking.
It's heartbreaking.
It really is.
And, you know, what do I say to my young daughters? You know, I got the wrong cancer.
Yep.
Like, if you get a more popular, common one, you get the funding.
And I would say, on top of that, you know, we can only do what we do because the community funds us.
Yeah.
So it is through grassroots fundraising in the community, corporates, etc., that we're able to provide nurses to be able to do that. We do have some support, which we're very grateful for from the federal government, but we can only provide these nurses because of that community support. So that gap in need is enormous, and equity has to be a key component in this discussion.
John, what's your work in the navigation space? You have done...
Well, yes, look, I was just going to comment, Caitlin's experience about being health literate, I don't think is unique. I think there's something about assuming the horizontal position that suddenly changes life, right?
Right.
And you're not standing on top of the patient, you actually become the patient. So I'm part of a group called All Can Australia, and we did a survey of 1,000 people with cancer, and the most important problem from their point of view was cancer navigation. So I absolutely think there's a real need to improve the way people navigate the system. The system is complicated.
Yes.
I'm a physician in the system. The system is complicated, and it doesn't matter what part of that system you have to work in or you interface with. So I think cancer navigation is really an important thing to do. I know the government is interested, and certainly we've also put forward submissions to think about how we could actually test this out in a way that allows everybody to actually have access to cancer navigators.
There's got to be an ethical element to that, Jane. I sometimes feel like when people find a navigation service, whether it's nurse-led or not, that they have something like a translator in an environment where they don't speak the language, and they get that, you know, that leg up and that help. There's got to be an ethical piece around that as well, as you say, about with equity.
Absolutely, and you know, you can think about ethics in terms of the patient's interests, and obviously that's in the patient's interest. It helps them navigate, it takes away stress, which only aids with, you know, recovery. But even if you look from a cost-benefit point of view, you know, like you said, the pressure on actual admissions, the pressure on departments is significantly decreased. When you can get people who have someone who can advocate for them, who knows the services available, it just makes everything more efficient. And so it just makes so much sense from a preventative point of view, from a cost efficiency point of view, and an equity point of view to make sure that everyone has a navigator.
Neil, can I get your thoughts on that?
Yeah, I couldn't agree more with it. And I think one of the things that's happened recently, science is moving so fast. You saw one of the quotes earlier on is, you know, we're moving in hyperpace, and standing still means we're going backwards. And I think, you know, patient access to clinical trials, patient access to on the PBS, the reality is we need to increase the transparency, set the targets, and then constantly hit that highest attainable level that we can have here. You know, we've got a strong community of here where things can happen, but they're not happening equitably. So we've got to make sure that we've got that consistency, but we've got to make sure that we're picking the things that really matter to patients. I think this is the piece which I'm really seeing through the report, but then also through just the conversations we're having more each and every day is, what do patients value? Where do they, as fundamental taxpayers of the country, what do they want to see their healthcare system evolve towards? And I think that this is just the start of it from my perspective. And I love the highest attainable standard, because I think whilst it's ambiguous, it sets the right tone. It's not better, it's best. And I think best is the way that we should be looking at here. We have all the fundamentals, from physicians to advocacy groups to the rule of law. We should set the aspirations for Australians to make sure that they get the best healthcare possible.
That's interesting. I'm going to do something tricky to you, John, and ask you, when Neil says we, from your perspective as a clinician, who is responsible for taking this forward? I think we all agree that there are patient centricity issues. It's ill-defined. There are people going without. Everybody seems to have goodwill here. But whose responsibility is the next step?
You didn't tell me about this question. So, having had a long experience, as you can tell, in healthcare, clinicians have tried. I think pharmaceutical companies have tried. I think in the end, this is about the patient, and I would like to see that the patients lead this. I think that in the end, if we're talking about access to drugs, for example, it's taxpayers funding access to drugs. The culture needs to be, how do we provide adequate care for our community? How do we provide that, not just adequate, how do we provide the highest attainable physical and mental health for our community? I think the community needs to lead that. And until the community leads it, it's going to be seen as vested interest groups, pharma, clinicians. The community needs to lead this, and the community will succeed.
Yeah. Absolutely. Do you think that the person standing in front of you saying, why can't I have it? I want to try it. What are the complexities for you as a clinician in the environment? How do you tell people there's no data, or it costs $12,000 a month, or as a clinician, how does that look?
So if we deal with what the cost is, the way I approach this personally is to ask, is there a reasonable assumption that this treatment may be helpful?
Right.
Whatever that treatment might be. It may be a drug, but it may be surgery, it may be radiation, it may be something else that we don't know about, including, for that matter, complementary therapies. Is there a reasonable assumption that it would help? And in the end, it's the patient's choice whether to take the risk, where the risk is unknown or there is uncertainty. If the circumstances are such that I think what's being suggested is unreasonable, I can only say that. And, but in general, that's not happening very often. Most often there's a reasonable assumption. Then the way I think about it is, let's deal with the access as a separate issue. So firstly, is there a reasonable assumption that it may help? And one can go to all sorts of lengths to understand that, right? So we've talked about genetic sequencing and understanding that in more detail. It was done once with a 50-gene panel. Would a 500-gene panel help? So let's look more deeply at the genetic sequencing. Let's look and see what evidence is available overseas. Let's see what people's international experience is. So now the reasonable assumption is created. Once it's created, then we've got an access issue. I think we just deal with that as a second-tier issue.
Yes.
It's really important, and it's often limiting. But let's solve it let's work out that the treatment may be helpful, and let's solve the access. And sometimes we can't solve it, and I accept that. But often we can find ways of doing it. Rare Cancers Australia is a fantastic resource, of course, for some patients. Other times institutions will pay. I think when the cost is $12,000 a month, I tell patients that it's $12,000 a month.
Yep.
Because I can't assume that that's something that's out of their realm, but for the majority, it clearly is.
Jane touched on that earlier, I think, making
We've got an
judgments.
obligation to tell people.
That's right.
Correct.
So, Caitlin, I happen to know that you have lived this reality, and you had some, I would say, episodes of luck to find a combination therapy, which cost an enormous amount of money. So, can you just give us a bit of insight, sort of the other side?
By the way, I'd love you to be my clinician if I had that kind of cancer, because, you've got the right approach. It's about giving those options to the patient. So I think I struggled when I recurred last year. The chemotherapy that worked the first time really well didn't work straight away, and no one expected that. And so we're scrambling to find something else to use. There were no clinical trials available. Now, I wasn't offered these drugs that I'm on at the moment because there wasn't a clinical trial available, and it was $12,000 a month. But I sought a few different opinions and spoke to my medical team and worked out that this is the best drug combo. I just want to give it a go. Because I had genomic testing, I knew what my tumour makeup was. And so that was my decision to make. That was my decision to say, okay, I'm happy to find this $12,000 a month. I'm willing to give that a go. But if I hadn't asked for that, it wouldn't have been offered to me. You should never assume that a patient won't be able to A, find the money or be able to pay for that or want to try something experimental. I think that's really great that you touched on that point about that comment from that patient broke my heart, that she just missed out or she missed out on that trial. And that happens all the time. I have patients that I know with ovarian cancer, friends that have not been offered these drugs and they're wondering why.
And you can understand, clinicians don't want to put someone in front of someone and say, it's this much, and have people heartbroken that they can't afford it. But if they can afford it and they can crowdfund and there are other options, and they find out later that, they're going to die because no one told them that they could raise this money to pay for the drug, that's not okay.
And we need to look at other cancers as well. So the reason I got this drug combo is because it worked in endometrial cancer, which is also quite aggressive and acts like clear cell ovarian, which I have. So it's understanding the science behind that. That's that true patient-centered care. Is doing, firstly, people have got to be offered the genetic testing of their tumours and a biopsy early on and biobanking, which is not consistent at all. And I had to push for that. And then with those results, to look around the world. We need a kind of portal, which I know Rare Cancers Australia are working on as well, where there's centralised real-time data. So I can say, okay, there's a woman with clear cell ovarian cancer in Singapore or America. What's she on? She's got the same genetic makeup as me. I was told there's only a handful of people with my makeup in the world. I'm so unique, yet I'm on this drug combo that's working. I want to shout that to the world. There'll be people that could benefit from that and could save their lives. Time is precious, Neil? Sorry.
No, thanks.
I could rant about this all day.
I can see that Neil is really...
No, I think from my perspective, the stories I hear is this is absolutely why the time to access to medicines in Australia must reduce. It must. If you're a patient right now, you do not have time. That's your variable, not cost. And I think from our perspective, where I see that pharmaceutical companies need to continue to work with government, with other stakeholders, is how do you take policy into action? You asked a question earlier on, how do I feel about patients being left behind? When you look at some of the times, it's devastating. Yeah. The question is do you accept a Japanese number around 90 to 100 days, or do you accept a German number at 0? Right. Highest attainable healthcare, which do you go for? So whatever it is, where we are right now, 90 is better than where we're at right now. So maybe that's the first stage in the perspective. But we must continue to do that. And with rare cancers, I think it's interesting as well, because we're going to have a great session later on around real world evidence. If you're in one of those rarest of diseases, they must be gathered together and used an amalgam of data to get these treatments onto the PBS, because right now, in that universal perspective, it's universal, but where does rare fit in? And that's right, not just in cancers, right, across rare diseases. And we're going to have to think differently, because science has, thankfully, moved forward so fast that there is optionality for patients now. So there's an exciting challenge, but we've got to get after it. And I think that that's the challenge about where are we going to spend first, second, third, fourth. Because we've all got to, in that community, play a part, whether it be nurse navigator, so once the drug's available, making sure that care really delivers the best outcome for the patient, but then also their families as well. Yep. So I think it's a really important perspective.
Yeah. And families and patients will have very different perspectives and different priorities. And supporting people to make the best decision for them with the information they have to hand is a critical part of that.
Can I just, we've got a couple of questions from the audience. I'll just, Neil, while we're on you, I'll just go to the one about pharma, which is regarding patient centricity. Is there a voice that pharma can put, I'll read the question directly. How can pharma companies support patient centricity and be a voice in front of government on behalf of patients? Do you see a role there for an interface between industry?
Absolutely. I think, whether it be the House of Representatives inquiry perspective, whether it be the Medicines Australia Strategic Agreement, whether it be the National Medicines Policy, whilst there are policy elements, they're not affecting patients. We really need to turn that into action and activity. And I think that that's where you see rare cancers, other patient advocacy groups working together to make sure that what we get, we work and interact with patients daily. The reality is we get to see their story in real life. I think that we have a responsibility to share that in order that, back to the earlier point, that Australians get the healthcare system that they want. not the one that they're having right now. So how do they decide where money is spent across the perspective? There's a lot of money that's in health right now given COVID. There's going to be budget balancing, but there is a real need in health to do more.
Absolutely.
There's going to be, and that's going to endure for the number of years. And we really need to be active as a community together to shape what that could be looking like in terms of priorities.
That's right, and not leaving patients outside out in the cold.
And as I mentioned, you know, the social contract that I talked about was simplified with those three parties, but all institutions that participate in society have a role to play.
Yeah,
you know, pharma companies have a lot of power and they need money to develop, you know, development and research in order to produce drugs, but they also have a role to play, and that's becoming more and more obvious. And I think companies and corporates are becoming more, you know, aligned with that idea that they need to think about more than just the bottom line.
John had a great point as well about all the different sectors not working together and having a coordinated effort. I think the conversation is becoming more obvious as we talk as an alliance and as a community and as a sector that no one party is really responsible. What do you think, very briefly, Caitlin? I've got another audience question and then I want to get everybody's closing thoughts. But what do you think about the solutions being patient-led?
Well, I think that's true patient-centred care, isn't it? I think you need to have the voice of the end user in any design.
Right.
It's human-centred design principles. Healthcare should be no different. And we need to get rid of that power imbalance and see patients, we are the best advocates for our own health. We know our bodies better than anybody. If clinicians take the time and be curious and actually ask questions and listen to the answer, they can find out all sorts of information which make their job easier and potentially, you know, help with health outcomes as well.
Yeah.
So I think absolutely the patient voice is a critical part of this.
Caitlin, we've got a question about navigators, which I'm going to put to you, Holly. What qualification and criteria are you recommending for navigators broadly when we start to hopefully expand out to all cancers?
I think the term navigator is used very widely.
Correct.
And it is not very clearly defined.
Right.
Many people use it in very different ways. And there are all sorts of navigation. There is, you know, technological navigation, there is telehealth, there is nurse-led, which may well be quite clinical in some aspects. And honestly, I think if we're going to find something that works really well and is cost-effective and delivers the outcomes that are important for patients, we need to consider how these things sit together. And they may look different at different phases also of the cancer lifespan.
Yep.
So we operate obviously with nurses, but they are very connected into their local environments. We have been looking at, through the scoping study, comparing what nurses by themselves would look like versus nurses combined with non-nursing navigators. So as a team that would work that, and whether that can still deliver the quality of outcome at a more efficient cost. And so I think we need to consider those. And the other part is technology is going to really race forward massively in the next couple of years. We understand the challenges in the system right now, otherwise we'd be a lot further down that pathway. But I think that we have to really consider what that's going to look like over the next 3 to 5 years. So agility and the ability to be able to say, right, what's coming down the road towards us? How can we embrace that and use that to drive what's important to the patient? So starting with that human-centred design that you've been talking about, Caitlin. At the moment, we know that we get great outcomes from a nurse cohort, and they're very experienced. You know, they have 5 years of cancer nursing, their postgrad certificate in breast cancer nursing. They're very, very experienced, highly qualified nurses. But that doesn't need to be the only solution, because I think that's limiting.
Yeah, that's right. I think that open-mindedness is really encouraging. We are running short of time. Unfortunately, I could talk to you all day, and we do have very important guests coming up right behind us, so we won't keep the minister waiting. Can I get your closing thoughts? I want you to give us your key messages for taking this conversation forward. Where are our solutions and opportunities? John, can I start with you?
So I like, I hadn't heard Jane talk about the social contract before, but I really like the concept, and I think my sense of the future really is this. I was talking about the patient of today and the patient of tomorrow, and my personal view is that the social contract obligates us to address the needs of the patient of today.
Yes.
Even though we've got responsibilities to the future. We've got responsibilities around appropriate use of taxpayers' funds. But we have a patient of today, and I believe that's where the social contract exists. And I'm not sure that we're achieving that, certainly with respect to some of the health technology assessment processes that we have.
Thanks, John.
And I hope that through this sort of process and patient centricity, we can address it.
Fantastic. Thanks for being such an open-minded and patient-centred clinician. Caitlin, can I get your closing thoughts on this concept?
Yeah, I think we need to empower patients to be able to advocate for themselves, and so they can be a part of these conversations. And we need top-down and bottom-up approaches. We need to change policy. We need to get these, patient navigators, I think, for everybody. But we also need to be able to support healthcare professionals to be able to have these compassionate conversations and to communicate well, have courageous conversations with their patients and make sure they're informed, whether it be by a central database. We have all data linked internationally.
Yeah, fascinating. Talking about the clinician, having those conversations is fascinating. We could have another session on that.
Yeah.
Neil, can I get your key messages, your take home on this?
I think the patient-centred era is here.
Yep.
We need to move forward faster than we've ever moved forward. I think we need to join the dots quicker, and we've got to listen. We've got to listen about what matters to patients and then change and reform. And I think my personal perspective is in moving fast, we can't seek perfection. We've got to get started, and then we've got to work it out on the way. And I really am excited by this. And the social contract piece today is just, I think, the higher attainable standard is where we should be and where we must have our focus.
Yeah, fantastic. That's really encouraging to hear from industry. Thanks so much, Neil. Holly, what's your key take home? Patient-centeredness, where are we going?
Honestly, it's so interesting to have this conversation, because where I was going to go was we have to move fast.
Yes.
And this is tough stuff. It's complex and it's difficult to sometimes get your arms around it. But only collectively can we do it. And sometimes good enough is good enough as long as we keep moving forward and learning. And I think in order to do that, you have to be clear from an ethics and a vision point of view where you're heading. And that's what you've been talking about really represents. So I think that collective approach, fast and learn, let's make it happen, because the patient of today matters and their voice has to be at the centre of it. But knowing where we're heading is the critical part.
Thanks, Jane. What's your key take home? Everybody's referenced the presentation this
I've spoken at length.
You've probably got about maybe 30 seconds.
30 seconds. In 30 seconds, everyone needs to be able to fulfil their role, and they need to be enabled to do that. Patients need to be listened to. Clinicians need to be enabled to be able to deliver healthcare to their patients. They need to be able to provide treatment. And so, the government needs to come to the party and provide funding, and provide it in the right way, not just throw money at something, but to listen to those priorities, to listen to patients, to listen to clinicians, and to provide that in the right way.
Thanks, Jane. I'm just checking whether the minister's joined us online. He's here. Thank you so much. That was brilliant. Thanks for thinking outside the bubble today.